Welcome to our video history. Today we're very fortunate to have Dr. Richard Paul, a noted maternal-fetal medicine specialist and a leader in many of the aspects of maternal care in our specialty. He's here with us today to talk to us. Richard, thank you very much for coming.
You're welcome.
We appreciate it. Let's begin so people can get to know you a little bit about your past history. Let's just start way back. Where were you born?
I was born in suburban Washington, in Tacoma Park, Maryland. His post office actually was in D.C., so I grew up in the Washington, D.C. area.
Most of your time in our specialty has been in California. How did you get to California?
Driving,
Well,
to
that's
start
true.
with. But I went through local university and undergraduate work in, again, Tacoma Park, Maryland, and then attended Loma Linda University in California and graduated from there in 1960.
Was that in medical school or undergrad?
That was medical school.
How did you get to Loma Linda?
It was the natural pathway in a sense for, it's a Seventh-day Adventist university, and I'd gone to undergraduate college in Washington. My mother was a nurse, and so this was a natural sort of place to go, and in 1960 it was relatively easy to get into medical school compared to today, and the tuition, of course, was $1,200 a year. So it was a different time.
Yes, it was a very different time. I mean, throughout that, when did you first decide to become a physician?
It was sort of an off and on thing, I think, you know. I mean, 18, 19-year-old guys have other things on their mind, often sports and activity like that. And I guess I really decided after my father said, you know, you want to work, you don't want to use your mind, go to work. And I worked in a nursery for $1 an hour, which was a prevailing wage. And after about a month or so of that, I said, maybe it's a better idea to get educated. And my mother's influence, I'm sure, had a play in that. She worked for a surgeon who I used to sail on the Chesapeake Bay with and crew for them. And somewhere along in that time frame, I said, well, I want to go into medicine in the late 1950s. So, well, not the late, in the mid-50s. Then I started in 1956 in medical school.
When in medical school did you decide you wanted to be an obstetrician-gynecologist?
I didn't decide in medical school. I felt that I wanted to go back east, and I was sort of had enough of California with the smog in the 50s. It was pretty tough. Said I want to go back where things are real, and I went back to Washington, D.C. In 1960 and interned, a rotating internship, and I had a rotation through a place called D.C. General Hospital. It's a place where a person named Gail V. Anderson had been involved in Georgetown, and it introduced me to a very exciting field of obstetrics, which at that time seemed, well, was easily comprehended and you could learn it. And I applied at Georgetown or GW and was accepted there as a resident, but then I had a meeting with a guy named Irv Nichols, who you would know from the college. He came to town and we went to his hotel room. He says, well, what are you going to do? He delivered one of my children. I said, I'm going to do obstetrics. I said, I would like you to consider. He says, well, you know, where were you in your class? I told him, so you want the job? I said yes, and it paid $250 a month instead of $200 a month, and so I said, I'll come back to California. So I came back to Los Angeles and did my residency at White Memorial Medical Center in Los Angeles, which was then the teaching hospital for Loma Linda.
Now, once you finished that, how did you get to the University of Southern California?
As a resident, there was a man working at the White Memorial named Edward Hahn, and he was doing all of this preliminary work with electronic fetal monitoring and massive machines, and as a resident, you know, you do what you're told to do, and so we did some very unusual procedures as it related to trying to understand the fetal heart rate that he was obtaining at that time, which was all really analyzed offline as opposed to online, and the decisions would be made clinically by the residents, and afterward then you'd look and see what these patterns were, and we did things like compress the umbilical cord and release it and give atropine and things that today seem very unusual. Fish the umbilical cord out at cesarean section with monitoring the baby's heart rate, and then actually canalized the umbilical arteries, and then could compress it and release it and look at the pattern. So the fundamental descriptions were being laid down then. Then he moved to Yale University in '64. I finished my residency, practiced for 1 year, and after a year of practice, I said, I think I want to do something else. So I went as a fellow to Yale to work with him. And the military said, wouldn't you like to join us for 2 years in the Navy? And I had a fabulous time with them. I went from this sort of experimental research-oriented thing back to the real world with residents at Portsmouth, Virginia, delivering 400 a month, which was a good-sized service. So I knew what could be done, but back to the basics, and then after that joined the faculty at Yale with a man named Ted Quilligan. And the next year then a group of us moved in 1969 to the University of Southern California, where a hospital had been vacated with 20 plus full-time equivalents available, to which Ted Quilligan recruited lots of folks, including Dan Michel, Dwayne Townsend, people that you would know well. And that's how I got there, and I stayed there 32 years.
It's interesting. Let's go back to the early time when you were working with Ed, because the impact that his fetal monitoring expertise has had on our specialty is basically immeasurable. How did he get this idea, and how did you get involved with it?
Well, I got involved as a resident because we were putting in catheters in the uterus through what's called a Drew Smythe catheter, which is a stainless steel thing, and you rupture the membranes high, and put on clips, electrodes, and you know, it was a fascinating thing to do as a resident. Now, his ideas had originated when he was previously at Yale with a man named Orvin Hess, who supported his research, where he took abdominal wall ECGs and measured them and then plotted out fetal heart rate. There was experimental work in the 1940s by Sir Joseph Barcroft on sheep, looking at heart rate responses to vagotomy, and one of his students was a guy named Don Barron, who was at Yale, and so there was this curiosity, well, you know, I was trained, and you may have been trained the same way. You listen once every 15 minutes or half hour, and that was it. If the heart rate was 140, it was fine. There was no such thing as patterns. But he then developed the technology to plot out and hand plot ECGs from the abdominal wall. You would mark them. It took 50 hours for every 1 hour of data that you recorded. And that was how the first descriptive patterns were shown in the late 1950s. And then he developed, with his background in radio engineering, he took skin clips, Michelle skin clips, and hooked wires to them and made electrodes which he could put on to the fetal scalp. And that revolutionized the ability to get better data online. So by the early 60s, there was online data, but nobody knew what it meant. I mean, you'd say, well, the rate never went below 120, and you'd be looking at, as a resident, I'd look at 5 hours of late deceleration or something, and suddenly the baby goes down and dies. But it never reached below 100, which was sort of where you called it fetal distress with auscultation. So the evolution of and recognition of patterns really came about in the in and around the mid-60s, and then were studied and evaluated. And one of the men that came to work with us was a man named Fred Kubley, professor at Heidelberg. He came with the express intent of showing that Salling's technique of fetal blood sampling was the way to deal with fetal care. So he set about to take samples, scalp samples, repetitively during continuous monitoring. And what he showed was the relationship of the patterns to the pH and the definitions then of, why you become acidemic, and that all happened in roughly the 67 to 68 time frame. So it was an evolving process, where the first clinical monitor went out from Yale in 1969, and that went to New York City, Metropolitan Hospital with Alan Weingold, because I went down there. Here's the monitor, and from there it just...
Was that a commercial monitor?
That was the first thing that was put in a box that could be taken anywhere. I mean, we had them at Yale. They were built in a lab, but that was the first commercial monitor that went out into clinical use. And then I think I think that was 68, 69 in that time frame. The first clinical monitor, and then one of the first learning experiences that was somewhat traumatic for me was to speak at the college meeting. I think it was in 1970, 71. It was called a clinical fetal monitor. And there was this big crowd of the college members, and that was the first, I think, public discussion of this device, which in fact could be used clinically.
I will share something with you. I was part of that audience sitting there.
Is that right?
Yes. I still remember the uniqueness of what is this?
Yeah.
Because when I was a resident, we had somebody was playing around with electrodes and things,
Well,
but
and
nothing like what...
You had these great big slides that were just glass lantern slides. I mean, it's because if you put a small slide in, it would burn up with the need for projection in a big room. So that was the first time I think I had my introduction to the clinical speaking about something. And By then, when we left Yale, the main reason that Quilligan, Hahn, and I left Yale was, in a year or so that we were doing this, we could monitor 300 patients. LA County and USC was a clinical learning site that pretty incomparable during the era of the 70s, 80s, and most of the 90s. And suddenly now, instead of 300, the next year it was 1,700, and then it was 3,500 patients, and then it just progressed from there. And it's important, I think, to understand that there wasn't, when this was introduced, there was no demand for randomized controlled trials. They didn't exist. There were no IRBs. It was a different time, and we actually, from USC, applied to the NIH in the early 70s to do a randomized controlled study at USC. They came and did a site visit, and I presented the data, I think, on 4,000 patients. Just, well, here's monitored, here's unmonitored. Very unelegant study. And this is the outcome with stillbirths and mortality. And NIH said, well, it would be unethical to perform a randomized controlled study, so they didn't fund that. And, we go through this debate still, well, why wasn't it done? And as some of my friends, one that lives in North Carolina, particularly writes, well, monitoring has never been proven to be A, B, and C. But we tried to do that even in its infancy, but it was felt it would have been unethical to do that by the funding people, so that never was done. I tried it one other time with my midwife service at the county, where they were delivering, I don't know, 4,000 or 5,000 a year. Said, let's do a randomized study in the midwife service. The midwives wouldn't have anything to do with it. They say, we won't live without it. So, you know the history of what's happened with electronic monitoring.
Yes, it's a very fascinating, but what you're telling us is about the early days, which I think very few people realize. How did you come up with the early terminology that you were using?
Well, there were two investigators doing this early work. And the person who did incredibly remarkable work was a man named Roberto Caldero Barcia in Montevideo. And he just did unbelievable things with the limited resources compared to what we had. He had called these decelerations dips, type 1 dip, type 2 dip. He used a scaling factor that slowed the paper up and also elongated it. So he didn't recognize, which we recognize now as 3 deceleration types: variable deceleration, late deceleration, and early deceleration. They were named based on the relationship of the deceleration to the onset of the heart rate fall. And so they were just descriptive initially. And then as we began to understand the pathophysiology, we started to call it cord compression. Late deceleration was then called uteroplacental insufficiency. Early was, well, I said head compression, late, and variable. But the initial terms were just descriptive because we didn't know the pathophysiology. But then we started to press on the baby's fontanelle and produce early deceleration and take the umbilical cord at cesarean with the baby in the uterus, open, cord out on, this is a resident, I was a resident, baby's heart rate stays the same. Compress the cord, here goes variable deceleration. And then there were things done where you put the patient on her back and she becomes hypotensive and you develop lates, then you turn her. So all of those things were worked out in the mid-60s as it related to the pathophysiology and the descriptive terms of uteroplacental insufficiency, cord compression, head compression, were then sort of labels that were put on early, late, and variable deceleration.
How did you feel as a resident and then as a young faculty being involved in basically the beginnings of monitoring?
Well, of course it's exciting and you don't know what it is. I mean, residents are excited about just doing everything. And I was just real lucky to be where I was. And I didn't understand how important this was, but I was at the right place at the right time with the right people, and that was just good fortune.
Well, you mentioned about cesarean section. I also wanted to talk to you a little bit about that, because you were one of the very, very first to come out and advocate that women could have a vaginal delivery after having had a prior cesarean.
Yeah.
How did you come to that decision?
Well, as a resident, I also worked at LA County Hospital. And when you work at a large volume hospital, you sometimes will get 3 patients, for instance, with prior sections. Well, if you got to start somewhere. And if you take the multip, I mean, I learned there that women could deliver safely after. That was as a resident. At LA County, when we went back there in the early 80s, we were starting to have a large volume. We averaged in that time frame usually 16,000 deliveries a year. On 2 occasions on rounds, there were 10 women who'd had prior sections in labor. And, you know, I said that, and I wrote it somewhere, and somebody says, well, that's statistically impossible. Well, you know, what can I say? I mean, I saw the patients, and you realize that you can't do all of that at one time. So with monitoring then, we undertook to attempt trial of labor and VBAC, and that was in the early 80s where we started that. And there was a big push, I think, at that time also by various organizations to decrease the section rate. And we would actually give a trial of labor to up to 3/4 of our patient population. Usually our population of women with prior section was 10 to 12% of women coming in with prior section. And we were successful then in roughly 2/3 of our attempts. And in a place where we were, we had 5, 6 residents, had staff, had anesthesia. We could react fairly quickly. But we then popularized, I guess, or at least espoused this technique, which then there was a lot of push to get it done. It went out to places that didn't have the resources that we had. And even though the incidence of rupture is 1% or less, it happens in a small, unequipped hospital, it's a total disaster. And you're well aware of those stories. I mean, what we could do, it was incorrect to assume everybody could do. And yet I think we provided information that subsequently people who have worked in the NIH CHD network did larger studies, and it's amazing. I think our total, or our population was around 12,000 that we had in our last publication in that area by David Miller. Essentially was duplicated by the NICHD because we just had this enormous benefit of being in a clinical laboratory that gave us a lot of information very quickly, which was a super place, plus good faculty and incredibly gifted residents.
As I recall, some of your first articles, you were having an 80+% success rate.
It could get that high, yeah. I mean, but overall, it depends on how you select, of course. You could get up to 80%. I mean, if you selected multips who'd had a previous vaginal birth, and then you did that, you get an 80% success rate. You take somebody with CPD as their first diagnosis, no vaginal birth, then it'd be 2/3. But overall, you could say safely 2 out of 3 that undertake a trial of labor would deliver vaginally.
Did you ever have any real catastrophes during this period of time?
Yeah, yeah.
As you look at those and do a retrospective analysis, what would have been the thing that you would have noticed that could have clued you in to the fact this might happen?
Well, I mean, being where, you know, during my career, I mean, I saw a lot of catastrophes because it encompassed about, I've calculated about 350,000 births. If you have a woman who, for instance, I remember well, has undiagnosed mitral valve disease and you give them a spinal, you know, they don't do well. And so I've seen maternal deaths that happen that way, and also associated with the dilemma of placenta previa accreta with bleeding. I think Steve Clark described that when he was a fellow with us, and so yeah, we saw disasters, but we saw a lot of success also.
As I look at the development of maternal-fetal medicine, you were obviously one of the first to really bring the whole subspecialty together. But you've trained literally hundreds of MFMs now around the country.
I know, I see the residents here that come and say, "Oh, Dr. Paul, you know, I just walking over your saw." She says, "Oh, thank you for the training." I says, "You know, it wasn't me, it was where we were, and you made us look good." Because we had incredible resources, and residents, I think, you know, probably there are 450 or so that trained, and many of them did maternal fetal, but it depends on how we define. If you take the actual maternal fetal fellows who trained for the American boards, I think that number is in the 120, 130 range. And then beyond that, I mean, we literally had people from Asia, China, Japan, all over Europe, who wouldn't always come for 2 years, but who would come for a year and then often go back and become leaders in their countries. So it was a pretty special place to be working.
It is different now, though.
Now?
Mm-hmm.
It's very different because I have not gone back to that institution for now 8 years. And I know what goes on indirectly, but they deliver now in a year less than we used to deliver in a month. So it's under 1,200, and that would be somewhat disappointing for me to have to deal with. So I just tend to say, I don't want to see that. They moved to a new hospital. I'll remember all of this fun stuff that we had, and my chairman, who you will interview, Dan Michel, he knows the history, and he was incredibly open and supportive in letting us run the division of maternal-fetal medicine for my tenure there, and you know, it was just a very special place to be. And I never wanted to be a chairman because I had more people in my division than most chairmen had in their department at that time. And it was, you know.
Well, Dick, you've been wonderful for you to come in and share this with me. You go back to history with Ted and Ed,
Yep.
and people who are really icons in the specialty,
Yep.
but you're also one.
Well,
I know you don't talk about it, but let me say, like those residents that come by and talk to you,
yeah.
you've helped change our specialty, all for the better of women. So thank you very much for being
Well,
here
you're
today.
welcome.
Appreciate it.
Thank you.